Hi, everybody. My name is Neil Seidman, and I'm co-chair of the Public Education Committee for ADAA. That's the Anxiety and Depression Association of America. And welcome to our webinar. And the title of our webinar is, Can Cognitive Behavioral Therapy Help with Neurological Disorders? And our presenter is a wonderful expert in this field, Dr. Suma Chand. And these webinars are presented by the Anxiety and Depression Association of America, which is the leading nonprofit organization in the field of anxiety and depression. And, our mission is to improve diagnosis and promote and advance the prevention, treatment, and cure of anxiety, depression, and stress-related disorders through education like this webinar, through practice, research. And I want to encourage everybody to take advantage of just the amazing resources on our website, adaa.org. One of the really great resources is our directory of treatment providers. So you just click on Find a Therapist from the homepage. And we also have a free peer-to-peer online support group, which you can also find from the homepage. And finally, if you have a question after watching the webinar, you can send an email to webinars@adaa.org. Finally, you can make a contribution to support ADAA on the website. Okay, so I'm really excited to get started. I want to introduce our presenter. Suma Chand, PhD, is a professor in the Department of Psychiatry and Behavioral Neuroscience at the St. Louis University School of Medicine. She's the director of their cognitive behavior therapy program and is also a board member of the National Social Anxiety Center. And she's also a member of the ADAA Public Education Committee. So let me turn it over now to Dr. Chand. Hi, Dr. Chand. Thank you so much for joining us.
Thank you, Neil. So I will start. Let me just reduce this.
Yeah, the slide looks good. It's coming through well. Thank you.
All right. So thank you so much, Neil, for your very nice introduction. So in this webinar, I will be talking about the role of cognitive behavioral therapy, or CBT, in helping patients with neurological disorders.
Yeah, and if I could just make a real quick point. So I think probably most of our audience has heard of cognitive behavioral therapy. And for those members of our audience that maybe aren't that familiar with CBT, it's a very effective approach, particularly for anxiety and depression. And it takes into account both the mind and the body. So that in a nutshell, but it's a very effective research-based approach.
Absolutely. So can CBT help with neurological disorders? I mean, that is something which people are not very aware of. So in this webinar, I will be trying to answer that question of how exactly CBT can help, and if at all, what exactly does it do? How can it help patients with neurological disorders? Neil, my slides are not moving
Yeah,
forward.
I know. I tried that myself, and sometimes the PowerPoint is hard to get it going.
Should.
There we go. Okay. Yeah.
Let me just. try it again. Oh, great. It's
There we
loading
go.
now.
Okay.
Okay. So psychiatric disorders are pretty common in patients with neurological disorders, and there have been some prevalent studies that have been carried out, and they have reported that the prevalence rates are more than 50%. So that's quite a large proportion of neurological patients who are also having psychiatric disorders along with the neurological disorders. And what are the two main disorders that you see very prominently in patients with neurological disorders? They are mainly mood and anxiety disorders.
And when you say mood, is that mostly talking about depression?
Absolutely. Yes, it's mainly depression.
So that slide, it had the statistic that, what was it, something like 40% of
Yes,
these
yes,
neurological conditions that you're going to talk to us about have either anxiety or depression, or maybe both in some cases.
that's right. That's
A
right.
large, a big percentage.
Yeah, it's pretty large proportion of neurological patients actually. Now, it's so important to target the psychiatric symptoms that we see in neurological patients because they have been found to be a major cause of disability. So the sooner they identified and addressed, the better it is, because we really don't want these patients to reach a stage of disability. Now, there's been another interesting finding, which I think really underlines the importance of targeting psychiatric symptoms and particularly depression. So what the research has found is that there is a bidirectional relationship between depression and neurological disorders. This means they sort of impact one another. There is an interactive kind of effect going on between the two. So
So
this
if
was,
I have one of these neurological conditions,
yeah,
it could lead to depression, but then what you're saying is it can work both ways, is my depression could actually make my disease symptoms worse.
yes, that's right. So on the
So,
other
so what,
hand,
so what you're talking about here with can CBT help? That it's like this is an opportunity possibly to maybe help with the physical symptoms as well.
correct. And so if you treat the depression, what happens is that it will have a positive impact on the neurological disorder. And when the
Wow.
neurological disorder gets better, it also has a good impact on the mood. The depression starts lifting even more. So you sort of set into motion a kind of positive upward spiral, if you can describe it like that. So it's really a win-win situation when you target both the psychiatric symptomatology or the depression and the neurological disorders. So this really underlines the importance of not neglecting the psychiatric disorders or symptomatology that can be present in many of our neurological patients.
Yeah. Wow. Very interesting.
Right. Now, pharmacological treatments for the psychiatric symptoms can definitely help, and they can
Right.
have a
Which is
beneficial
true for
impact.
people that don't have the neurological diseases as well, of course. Like, I guess
Yeah,
most people have heard more about the SSRIs, like the Prozac, Lexapro, Zoloft family of
right.
medications for anxiety and depression. So those might also be used for someone that has a neurological condition and has anxiety or depression.
Totally. There is, however, you have to be a little careful when you use them in patients who also have neurological disorders because of the interactions with the medications they are on. There is some risk of adverse events, and the side effects actually can also make it difficult for patients. Many of them discontinue the medications because of the side effects, and that, ends up having a negative impact on the symptoms. They don't really improve in that case. So cognitive behavioral therapy is a very good non-pharmacological option because, as you mentioned already, it's a very well-established, effective treatment, and it has been, recognized as an evidence-based treatment for mood and anxiety disorders. So why not
So if there
use
was a
this?
way of, sorry to interrupt, so if there was a way of bringing some CBT on board to help someone with one of the neurological conditions you're going to talk to us about, that could really have a big positive effect on someone's life, especially if the role of medication for anxiety and depression is limited because I have a neurological condition and the side effects could really be a problem for me.
Right. Absolutely. So I will talk about each of the disorders where there's been some research carried out on the impact of CBT in treating the psychiatric symptoms that are present in each of these disorders. So I'll start with Parkinson's disease, or PD in short. So patients with Parkinson's disease typically have a mix of depression and anxiety symptoms, and it affects about 50% of PD patients.
Wow.
Yeah. Again, that's a very
staggering.
big,
That's
yes.
staggering, Dr. Chand.
Yes. And in treating them with medications, there is a concern about the negative impact of using several medications. And they've also found that when there's anxiety present, then the antidepressant medications are not as effective in their impact, in particularly in Parkinson's patients. So this really makes a case for a non-pharmacological approach like CBT. Now, there have been some studies that have looked at the efficacy of CBT in treating the depressive and anxiety symptoms in PD patients, and they have reported significant benefits for patients.
So that's interesting. So there's already been some good research on
Yes.
bringing CBT on board for patients that are suffering with Parkinson's disease. And from like your first slide about Parkinson's disease, about half of people with Parkinson's disease could benefit from CBT.
Yes,
Wow.
definitely. So, the good thing about some of these studies that have been carried out is that they've also done like considerable amount of, follow-up. So this follow-up kind of evaluation to see, is the treatment effect still there? Is the CBT still continuing to have an impact on these patients? And the follow-ups have ranged from 1 to 6 months, and they have found that the benefits are remaining. So this is actually one of the strong points of CBT, one of the strong suits, because the impact tends to be long-lasting. CBT does prevent relapse.
So somebody might get, say, what would a typical course of CBT be? Maybe a dozen sessions, or depending on what the insurance might provide?
Yeah, somewhere to 15 to 16
15,
sessions.
16, yeah. But then the benefits, like you were saying, with the research that's been done, that the benefits continue.
Yes, that's right. So, I would say that one of the reasons why CBT, has this long-lasting impact and is a pretty resilient treatment is firstly because, it is a didactic kind of, there's a teaching element in CBT. People learn and acquire skills and strategies. And that's something they can continue to apply lifelong. So even if there is
and especially if it's something that's helping me, I'm going to have maybe some motivation to keep practicing. And then if I'm getting, like you were saying, 12, 16 sessions, that's enough sessions to really learn and reinforce those skills that hopefully are going to help me.
Yes, absolutely. So, so even if they feel like, later on the symptoms are coming back on, there's any kind of resurgence, they know exactly what to do. Then the other thing is that even in the course of the CBT sessions, in the course of therapy, there are some beneficial changes that occur which remain. They develop healthier adaptive patterns of thinking. They learn about cognitive distortions and they're able to recognize them and correct them. So there is that kind of modification in their thinking patterns. They also tend to start modifying their behaviors that have been maladaptive and not very helpful and have resulted in negative outcome. They start giving that up because they recognize in the course of therapy that it's not really helpful. They also get better at regulating their negative emotions on the whole. So there are a lot of changes that also happen in the course of CBT which tend to stick.
Oh, very promising to hear.
Right. Now, even when you look at these studies that have been carried out, the CBT studies on patients with Parkinson's, the researchers have taken care to modify the protocol so that they are tailored to deal with some of the symptoms, the difficulties PD patients have with some of the symptoms. Like they have this on-off PD symptom effects. So
Right. So anybody in our audience that's familiar with Parkinson's disease is going to know what that means, where it's like they can move
right,
for 5 minutes and then and then they're, having a hard time on off.
right. So it's like, they have tremors, they have difficulties with their balance, and they can be doing okay, but the symptoms can suddenly come back on. And you see this actually in patients who have Parkinson's for many years. The disease is progressing, so the medications are not as effective. It's a progressive, deteriorating
Right.
illness. So after, of course, it takes a long time. It takes many years. But in the later stages, the medications cannot really help beyond a point. So they can
Yeah.
have these kinds of symptoms coming back on, and it can be unpredictable.
So what I'm hearing is that, and we wouldn't have time in our webinar to get into a lot of detail, but what I'm hearing is that what these researchers worked on is ways of bringing the CBT on board, but in a very specific way to help the Parkinson's patient with these kinds of specific challenges that
Right.
Parkinson's patients have to deal with.
Right. Sometimes their motor symptoms can act like a trigger for anxiety. When they start shaking and having tremors in a public place, like in a restaurant when they're eating, it can make them feel pretty anxious. So these kinds of problems are also, addressed in the CBT. Then there is a fear of falling because your walking gets impacted.
Uh-huh.
And, very importantly, they have to actually prepare them for disease progression. And that's also been taken into consideration in the CBT protocols.
Wow, wonderful to hear.
Yeah. So, I had a elderly lady I was seeing with Parkinson's disease, and we really worked quite a bit on the preparation for disease progression. It was particularly important for her because she was, in her 70s and she was living alone. She had a grandson living with her. He was an adolescent boy, he was a teenager, about 15 years old, and she had taken responsibility for his upbringing. And she was
Wow.
very,
So she was parenting a teenager and dealing with Parkinson's, and this was
yes.
yeah.
So, she was very concerned as to what would happen to her grandson because she was recognizing that her disease was progressing and she was beginning to think of moving into a skilled nursing facility. But she said, what would happen to my grandson? So we sort of addressed that in our CBT sessions as well, identifying different options, doing cost benefit analysis, talking to the grandson. So, these are things that need to be addressed. We cannot neglect them when you have a patient with a disease like this. And the researchers have sort of taken that into consideration in the CBT protocols.
And was that helpful to her in
Oh, yeah, definitely. It was very, very helpful.
yeah. So that's something that there's no way a medication could help, directly with that kind of situation, but cognitive behavioral therapy really
Yes.
taken on board really could help her dramatically with those challenges.
Yeah, so problem solving is also a big part of CBT, so we do work with problems that patients face. And also the strategies, the researchers made modifications in the strategies. So some of the modifications were using less written work. There is a considerable amount of written work that we do in CBT. When we do cognitive restructuring, we have patients to write down their thoughts and, to sort of examine those thoughts, and we use certain formats. But when when they had the tremors, it was very difficult for them to write. So with one of my patients, what I did was, I used to actually write for her in session. She would speak aloud and I would write, but she could type comfortably. So for homework, she would type up her work and she would print it out and bring it. But in session, I would write for her. Then things like tailoring the activity scheduling to accommodate the PD symptoms is something that we do. So, we often use activity scheduling for depression, where we get patients to engage in activities that give them pleasure or give them a sense of satisfaction.
Or
But then,
moving the body, taking a walk, exercise. So that
yes,
you tailor that to somebody with Parkinson's, you'd have to get pretty specific.
Right, right. So for her, actually, she loved to read, but once tremor became a bit bad, she couldn't hold the book and she couldn't follow what was written. So we sort of, tried different options. We thought of audiobooks, and then she finally settled on, downloading books on her computer and reading there. But we sort of address these issues and think of the PD symptoms and accommodate them so they can, still engage in some of these activities and not give up.
It sounds like there was quite a bit of creativity involved.
Oh yes, totally. Actually, she couldn't drive. That's a common problem patients with Parkinson's have. So she managed to get a little chair, kind of a scooter, and we sort of identified where are some of the, the adult older centers for older adults, because her socialization was so limited. So we located one nearby so that she could go there using her scooter. So these are things we sort of address in the session. So she's not so isolated and not so lonely.
So I just want to make a point for our audience. So these kinds of very specific problem solving and creativity approaches are part of the CBT approach.
Yes.
Yeah,
And
wonderful.
even caregiver education has been incorporated into the protocols. And this is so helpful because, caregivers have to be educated not only about the Parkinson's disease, but also about the psychiatric symptoms and also about the CBT strategies. In fact, for some of my patients, I have the caregivers actually sitting in on the CBT sessions, or at least parts of them, so they know exactly what is going on and they can help the patients, at home, and they can encourage them and sort of act like co-therapists. So for instance,
Uh-huh.
like the deep breathing exercises, the initial stages, for instance, if a PD patient becomes very panic stricken or experiences high levels of anxiety, the caregiver can guide them through the breathing exercises. And because they know what it's all about, they become effective kind of co-therapists. And I think it also makes the caregivers feel more empowered because they know what to do. They're not so helpless.
I think that's just a wonderful element here that the caregivers can be brought into the CBT.
Yes.
Wonderful.
Moving on to multiple sclerosis. Now, again, a very large proportion of patients, 50% of patients with MS, will have a major depressive episode during the course of their illness. And suicidal ideation has been reported as being pretty high in MS patients with depression. So the depression that they have can be pretty severe. And, I'm not really surprised that the depression can be severe in MS patients because the patients who are afflicted with MS can be quite young. It can start early. So it is quite a devastating kind of diagnosis to have for a young person. So I recall, one of the patients I saw, it was really sad because she was a young girl. She was getting ready to start university. She had been accepted and she was working a summer job, waitressing. And she started noticing that, she was having episodes when she would become rather clumsy. And this was becoming a problem because she was dropping and breaking dishes and plates at her job. So she talked to her primary doctor and he referred her on to a neurologist, and she was diagnosed with multiple sclerosis. And it was such a devastating diagnosis for her. So it's not surprising that, young people, being told that they have this kind of illness which can change the whole course of their life, it's not surprising that they become so depressed. And it's so very important they get the support and help of a non-pharmacological kind of treatment like CBT.
And then also I see on the slide at the bottom of the slide that the medications for depression can be limited because of the potential for side effects uh,
Right.
are going to be could be a big problem for someone with MS.
That's right. And they also are already on other medications. So they, if they have side effects or adverse, risk factors, and they don't want that added kind of burden. Now, with regard to studies that have looked at the impact of CBT, they have reported that they are beneficial, that the CBT has a beneficial impact on depression in MS patients. And again, some of the researchers have used protocols that have addressed the specific problems associated with MS, like the fatigue, the pain, and the social and interpersonal difficulties resulting from the disease. And actually, the social and interpersonal difficulties can be a pretty major issue for people with MS. For example, I recall seeing a young girl who talked about how she had a very close relationship with her mother and brother, and they were a pretty close-knit family. But once she developed MS, I think the dynamics of their relationship changed. She sort of felt she became a little bit of an outsider. And I think the mother also, I think, showing some signs of frustration, because I think she was not ready to become a caregiver at this stage in her life. That is not something she expected. So I think it was pretty heartbreaking for her. For some of the young people also, they can no longer do some of the things that they used to do with their friends. Like one of the other patients I was mentioning, she had a group of friends that she used to go clubbing with on the weekends. And she can't do any of those things anymore, because after a period of time, sometimes they're using a walker, sometimes they're in their wheelchair, so they suddenly find themselves, out of the loop. They don't have that old social circle anymore, and they don't have
So
people.
so I'm just thinking, like, what a dramatic impact it could have on someone's life with,
Yes.
especially maybe somebody so young, but anybody with MS, to be able to have another resource, and we're talking about CBT, to help them address these kinds of challenges.
Yes, absolutely. They need it a lot. And interestingly, it's one very good thing is that they've even tested out CBT delivered through the telephone, and they found it to be effective. So that's really good to know, especially because MS patients, they have motor symptoms, and so they cannot drive, and they don't always have people available who can, drive them to their therapy sessions, or they may not have CBT providers in the area where they are living. So it's very good that, even CBT delivered over the telephone can have a good effect.
Wonderful.
Then you have computer-based CBT, but that is helpful for mild to moderate depression. And the therapist-guided internet-based interventions have reported better results. And I'm not surprised. I think we do need a therapist at the other end of the internet who is, more aware of what's going on with the patient and can individualize the sessions to adapt to what's going on with the patient.
Mm-hmm.
And again, there are the studies that have been carried out. They do have some limitations. There are not a lot of them, but they all suggest that CBT is beneficial, especially when it's tailored to the specific difficulties associated with MS.
Yeah. So what I'm hearing, because each of these neurological conditions is different, that what I'm hearing is that the main psychological challenge for MS is depression, and that's where the focus might be with bringing the CBT on board.
Right. They do have anxiety as well, but it's much less. So, depression prevalence rates are about 50%. The anxiety disorders prevalence rates are about 21.9%, as has been reported in one study.
Okay. Yeah. And so for those people, for that segment, the CBT that's tailored for their anxiety can also be helpful.
Absolutely. Unfortunately, there have not been many studies carried out targeting the anxiety symptoms. There are a few which have been carried out that have targeted the self-injection anxiety. A big part of the treatment is where they have to inject themselves. And if if a person is afraid to inject himself, then it impacts the treatment compliance. So CBT, there's a small study that has, examined this impact of CBT, and they found there were, out of the 8 participants, they all got over their anxiety by the end of the 8th session, and 7 out of the 8 subjects were injecting themselves by the end of the sessions, and they continue to do so at the 3-month point. And
so what I'm hearing again is this is like another example of how CBT can get very specific in helping the patient with a specific challenge, and an anxiety challenge for somebody with MS might be, well, I'm supposed to inject myself, but I'm too anxious about doing that. And CBT in just a few sessions could help people with something like that.
Right, right. So the eighth patient, as I was mentioning, he did manage to start injecting himself, but it was a couple of months down the line. I mean, he was able to continue, do so.
Yeah.
Now,
Only
CBT.
8 sessions. Boy, I'm reading
Yes,
that slide. 7 out of 8, and only 8 sessions were helped. Wow.
right. And they were able to do the same thing by using CBT over the telephone. So that's so good to know that it works even over the telephone. Now, moving on to stroke, the most common psychiatric disturbances seen are again depression and anxiety. And depression seems to be more prevalent because it has been reported to occur in about 40% of patients after an acute stroke. And the research indicates that post-stroke depression is significantly associated with poor prognosis. So it also.
And one of the first points you made at the very beginning of the webinar was about how depression and the physical symptoms can be a two-way street, where
Right.
that can make the physical symptoms worse, and then of course the physical symptoms can increase my depression. And then what you're pointing to here for stroke is someone that has significant depression that is not going to be helpful for their physical symptoms.
Absolutely, yeah. And again, antidepressants have been found to be beneficial, but in the case of some of the antidepressants, there is a risk of adverse effects. Now, they're not actually the studies that have examined the impact of CBT in treating post-stroke depression is pretty limited. And in fact, it's only in 2018 we have what is known as a meta-analytic study. In a meta-analytic study, what they do is they take a couple of studies which have been well designed, and they examine the results through a common lens. And this meta-analytic study reported that both CBT by itself as well as CBT combined with the antidepressants significantly improved depressive symptoms and also remission rates in post-stroke depression.
Okay, so that's again very promising. Again, the idea of somebody with that's had stroke might be very limited in what they can do physically, but if there's a way of bringing CBT on board, could be very helpful.
Yes, totally. Moving on to epilepsy, major depression has been reported to be the most common psychiatric conditions, and the prevalence rates are less in those patients where the epilepsy is controlled. It's about 3.9%. But in patients where the epilepsy is not well controlled and they're continuing to have seizures, the prevalence rates are much higher. It ranges from 20 to 55%. And again, the depression seems to be quite severe because they have also reported a high rate of completed suicide in these patients.
Oh boy.
Yeah, and the depression has also been reported to have a negative impact on seizure control.
So again, it's another example of where the depression can affect the actual physical symptoms.
Right. So it becomes, so crucial that the depression be treated or the psychiatric symptoms be treated. But unfortunately, in patients with epilepsy, despite the high prevalence and the negative impact the depression has on patients who have epilepsy, it remains untreated. The depression is usually not treated. Now, there are certain reasons for this. One is the fact that physicians are concerned about the antidepressant medications lowering the seizure threshold, because if that happens, then the seizures won't be well controlled. So they're concerned about also the adverse drug interactions between antidepressants and anti-epileptic drugs. So because of this, they don't treat them using medications. So depression is not treated using medications.
So then what's left? Well, how about some CBT?
That's right. This research studies in there's looking at the efficacy of CBT have been limited. In fact, some of the studies have looked to see whether CBT would reduce the seizure frequency. So focusing on the seizure frequency has not been that helpful, but there have been some studies that have focused on really improving the depression, and those
Right,
studies.
and that's what we're going for with the CBT is
Yes.
the depression, right?
Yeah, I'm not so sure. I've not looked at those studies. I'm not sure what they were trying to do to reduce the seizure frequency, but definitely the way to go would be to reduce the depression. And they found that that definitely helps in patients with epilepsy. So it helps the depression. It also helps with the distress associated with epilepsy. So they have concluded, finally, there have been some systematic reviews carried out which have concluded that CBT interventions that were tailored to improve the depression does help, but not those that focused on seizure control. See, mindfulness-based CBT is something that came about later, and they have even tested out CBT with the mindfulness component. And they have tested it out via the internet, the telephone, and they've also used the group format and found that all these different options do work to reduce the the depression. So
And would it be a common experience today in 2019 if I'm getting CBT for myself or a loved one that has one of these conditions, that there might be a mindfulness part of that approach?
Yeah, totally. Actually, I think with both anxiety disorders and depression, I personally incorporate it every time. And you give it as an option to patients. Some of them are not very keen. They somehow don't get hooked onto it. But some of them really do, and they like it, and they really benefit from it.
Right. And in fact, I think we just did a webinar. So if people want to Google for another one of our webinars, a mindful way through anxiety.
Right.
So that's what's been happening in the CBT field, is incorporating more of a mindfulness approach. And we don't have in our webinar to talk about mindfulness, but it's one of the elements of CBT that can be very helpful.
Definitely. And it's interesting, they've also used it in a group format. So the group format is very cost effective. You're able to address like a couple of people at the same time. So it's cost effective. And I really like groups, but especially for people who are suffering from a medical or neurological condition, because they are able to support each other in a group setting, and they feel that sense of somebody who really understands what I'm going through. They can't talk about it, or people may not understand people around them, their families, or friends or relatives, but talking to somebody else who's going through the same thing they're going through is very helpful. And that kind of support, I think, also helps with the depression. So, based on the available research evidence, international consensus clinical practice statement for the treatment of neuropsychiatric conditions associated with epilepsy has recommended CBT as a psychological treatment of choice for depression in individuals for epilepsy.
I'm so impressed with your presentation today, because even though it sounds like these studies are very recent and it's like a pretty new area of research, but every one of these conditions, there's some good research that shows, based on research, it's not just, oh, this could be a good idea, but there's really research that demonstrates that bringing CBT on board can really be helpful.
Yeah, totally. Finally, coming to myasthenia gravis, patients with myasthenia gravis experience both depression and anxiety disorders. They're quite frequent. And these patients actually have a higher prevalence of anxiety disorders compared with the other neurological illnesses. And I'm not surprised that they experience more anxiety, because patients with myasthenia gravis experience some of these acute crises, and they can be quite frightening. And I'll be talking a little bit more about the crisis when I talk about a case which I have published 2 years back. And in addition to mood and anxiety disorders, they also have a high prevalence of insomnia. Again, in the using medications to treat the mood and anxiety disorders in MG patients, there has to be caution because of the potential adverse reactions they can trigger. Now, there is, very, very limited research carried out on psychological interventions to treat the depression, anxiety, and insomnia that is seen in MG patients. So I published a case study. This was a case that was referred to me by a neurologist. Actually, I worked in a department which was a combined neurology and psychiatry department. So the neurologists were very aware of CBT thanks to me. So they used to refer patients to me. So I published this case, which was referred to me by Dr. Kaminsky, who was seeing that he's an expert in myasthenia gravis, and he referred this patient to me. So what had happened to this patient was that she developed a myasthenia gravis crisis, and this was in the early stages when she'd just been diagnosed with myasthenia gravis. And this crisis actually impacted her, the muscles associated with the lungs, surrounding the lungs. So it impacted her ability to breathe. The lungs were not functioning as they should, and she went into a crisis. She was rushed to hospital and she was taken into the ICU. She had to be ventilated. So it was a very, very frightening experience. I think if that were to happen to you and me, we would be extremely anxious. There's no escaping the fear when something like this happens. So what happened to her was that when she was hospitalized itself, she became so afraid that she would go into a crisis again in her sleep, and that she would die as a result of it. Of course, she was hooked on to all these machines that were monitoring all her functions, and there were nurses around the clock, but she just couldn't get over that fear that something could happen to her and she could pass away in her sleep. So that is why she just couldn't sleep, and her sleep was, she was barely sleeping for 2 hours actually when she was in hospital. And then when she came to see me, she was much better. She was discharged from hospital at that time. But her fear of, of not being able to breathe, going into a crisis, kept her awake at night. And her sleep was very disturbed. It was very poor quality and very, very few hours. And she was also very concerned about the fact that she was not sleeping. The myasthenia made her very fatigued. So the myasthenia itself caused the fatigue, and the not sleeping also caused her more fatigue. And then she became worried that I'm so fatigued, this is going to make my myasthenia worse. So it was a kind of a vicious cycle. She was also concerned about how the myasthenia would impact her ability to work. She was upset that she couldn't really help out in doing any chores at home. She felt she was burdening her family, her husband, her adult children. So she was very anxious and depressed and sleepless when she came to see me. But again, she was very interested in the therapy, in the CBT. She was very compliant, and we worked really well together. And she began to get better quite quickly. By the end of about 7 sessions, she was sleeping so much better. She was getting about 7 hours of sleep. Her anxiety became.
Wow, in only that many sessions. That's phenomenal.
Yes, and she was, her depression and anxiety also lifted. And actually, before I was publishing this case study, I contacted her because I just wanted to know how she was doing. And she said she was doing well. And interestingly, she told me, I'm still using some of the, strategies that you taught me in the course of our CBT sessions, like the progressive muscle relaxation. She said, I still do that. And she still remembered some of the cognitive restructuring that we had done in the course of our CBT sessions. So that's why it was good to see that kind of resilience, of the CBT, which I had done with her. It was actual proof. I was seeing her after 19 months, and she was, still applying some of the strategies, and she still remembered what we had done in those sessions. So the outcome really underlined the utility of using CBT in treating a patient with myasthenia gravis. So summing up, I would say that although the research is limited, but it's very, very promising. And, importantly, research has also identified the fact that neurological patients do prefer non-pharmacological approaches to treat their psychiatric symptoms. And the lack of adverse risk factors and side effects, again, makes CBT a very useful and beneficial treatment option for neurological patients who have psychiatric symptoms. So I hope you found this webinar useful. To all of you who are listening.
Wonderful presentation. Now, if I'm imagining being in the audience, being one of the viewers, and whether it's myself or a loved one that has one of these neurological conditions, how can I go about finding CBT? And you and I talked before our webinar today.
Right.
Let's just share with our audience, I guess, the three main. Oh, you did a slide. Wonderful. Great.
Yeah.
So we have ADAA.org, and then you could just go to that homepage and click on Find a Therapist. That's our organization, but there are two other wonderful organizations that really focus on CBT. The first one is, what is that? The Association of Behavior and Cognitive Therapy.
Correct.
Yeah, so that's abct.org. And then the third one is the Academy of Cognitive Therapy, academyofct.org. So these are three really great websites that have directories of CBT therapists that you can go to see if you can find somebody in your area. Now, if I live in an area that is not near a big city and maybe there's no CBT provider near me, I still might be able to find a CBT provider that would be willing to work with me or my loved one by phone or Skype.
Right. So I think these lists, these Find a Therapist, they would mention, on their bio whether they do that.
Yeah, great. Wonderful. Well, thank you so much, Dr. Chand, for your presentation.
Not at all.
And I want to thank everybody for tuning in. I want to encourage our viewers, if you enjoyed the program, got something out of it, click on the like it button, share it with friends and family. And then again, if you have questions, you can email your questions to webinars@adaa.org. So thanks again, everybody, for watching, and we'll see you next time.
Bye-bye.